I call this meeting to order. Welcome to meeting number 57 of the House of Commons Standing Committee on Health. Today we meet with witnesses for the final panel in relation to the study of children's health. I've also saved some time at the end of the meeting for committee business so that we can consider study budgets and the amendment deadlines for the upcoming meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. Just a couple of comments for the benefit of, primarily for the benefit of witnesses, all of whom are online today. Interpretation for you is at the bottom of your screen. You have the choice of either floor, English, or French. Screenshots or photos of your screen are not permitted. The proceedings today will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I would now like to welcome our witnesses who are with us this afternoon by video conference. Professor Nathalie Granvaux de l'Université.
We have Professor Nathalie Granvaux from the University of Montreal, Professor Alain Lamarre, full Professor, Institut National de la Recherche.
Of the Pediatric Surgical Chiefs of Canada, and Patsy McKinney, Executive Director of the Under One Sky Friendship Centre. Thank you all for taking the time to be with us today. Each of you has up to 5 minutes for your opening statement. Et nous allons commencer.
And we will begin with Professor Granvaux. I welcome you and give you the floor. Thank you very much, Chair. Thank you, Chair, members of the committee. Thank you for giving me the opportunity to appear as a full professor from the University of Montreal and the Research Laboratory on Host Virus Interactions at the CHUM in Montreal. I was a lead in the until 2020 in the COVID pandemic rapid response team. I have no conflict of interest to declare.
The initial outbreak of COVID-19, it was evident that children were much less affected by severe acute respiratory symptoms than adults, and particularly the elderly. This observation guided initial public health policies, and children were included in population health measures to limit the general impact of COVID-19 on vulnerable people and protect the capacity of our health systems, rather than to specifically protect their health. Across Canada, different measures have been taken to limit the transmission of the virus, including at different times the closure of school, the use of remote education, mask mandate, vaccination, or the use of air purifier. It is reasonable to note that these measures have certainly had a negative impact as described by social science experts. The optimistic assessment of the start of the pandemic regarding the impact of COVID-19 on children has led to many questions about the relevance of the sanitary measures imposed on children. However, considering that knowledge of the COVID-19 has only been made as the pandemic has progressed, several scientists, including myself, have supported the application of the precautionary principle in the management of COVID-19 for children. So what is the state of knowledge after 3 years of pandemic? First, the airborne transmission of SARS-CoV-2 is now recognized by the World Health Organization and other public health bodies and has achieved consensus among the scientific community. It is now clearly established that COVID-19 is transmitted at school and spread from school to homes. Not all children are equal when it comes to complications for COVID-19, and some other children are also living with relatives who have vulnerabilities to complications related to COVID-19. The first serious complication observed in children was the multi-system inflammatory syndrome, which had an incidence of up to 6 to 10% depending on the age group, according to certain studies before 2022. The Omicron variant, however, led to a significant increase in transmission among children, accompanied by a major increase in hospitalization. It is now clearly established also that COVID-19 is not a disease of the respiratory system only. The acute phase presentation was only the tip of the iceberg. There is no ample evidence of the short and long-term effects of infection and reinfections. Several studies have now described neurological, cardiovascular, and other multi-system impacts of COVID-19 in adults and children, independently of the initial presentation of the disease. And we can easily imagine that long-term illness will have a major impact on the social well-being and learning ability of children. The immunity established by vaccine and past infection does not confer complete and infinite protection against reinfection. Immunity to SARS-CoV-2 infection remains relatively short, leaving children vulnerable to reinfection, leading to lost learning days. So we have made a lot of progress in the face of COVID-19. It must be recognized. However, we must draw lessons from our current knowledge, and the risk of SARS-CoV-2 infection on children cannot be ignored. So what is the avenue that we should take in this context to ensure in the least restrictive way possible the health, but also the learning of children? So were we right to use method to limiting transmission in school, given what we know today? My answer is most definitely yes. The precautionary principle and the measure put in place have made it possible to limit infection that have potential for long-term effects. Relying on hybrid immunity established by vaccination and repetitive infection involves the risk of developing long-term complication, the post-vaccination rate of which remain to be determined with accuracy. The risk is not acceptable. So there is an urgent need to consider airborne transmission of SARS-CoV-2 in infection prevention and control. Ignoring it is no longer an option for the long-term management of COVID-19. One of the key measures that must become a priority in our schools, but also in busy public and private environment, is the improvement of indoor air quality through sustainable measures which do not depend on individual human behavior. Some countries have already committed to implementing such measures, and we must follow in their footsteps to enable a passive reduction of airborne transmission and thus reduce the need for the use of restrictive personal protective measures. Good indoor air quality has the advantage of protecting against COVID-19, but also independent of circulating variants, but also it protects again a wide range of respiratory infection. So improving indoor air quality is a new frontier in public health, requiring commitment from our leaders at both local and political level. And just as access to clean water has eliminated the transmission of certain infections in the past, improving air quality will reduce the impact of airborne viral infections. Thank you.
Thank you, Dr. Granvaux. Next, we're going to hear from Dr. Alain Lamar, Institut National de la Recherche Scientifique.
Welcome to the committee, Dr. Lamar. You have the floor. Thank you very much, Chair. I would like to thank the committee for the invitation to participate in this meeting. I am a professor researcher at the Centre Armand Frappier research at biotechnological research at the National Research Institute in Laval. I have been working in this field for more than 30 years and hold the Jean-Jacques and Louise Lévesque chair in immunovirology. I am particularly interested in new vaccines that emerge and also how children react to vaccinations. Certainly, COVID has brought an intense focus on health and immunization and the education of young children in Canada, not to mention Indigenous peoples. Amongst the negative effects of the pandemic, we can see that there was, on the long term, a drop in the education of children, and we also know that the vaccine coverage, immunization, is dropping. Also, there is the disinformation campaign that was waged against COVID-19, which engendered some fear amongst parents. They were afraid to have their children vaccinated. And so it is essential that we deal with this, that we give more information to the population at large and give them reliable information with respect to vaccination so that they can make informed decisions about vaccinating their children. I'd like to take a few minutes now just to talk about the importance of research in Canada, and in particular, research in the area of child diseases. We know that there can be a great effect when new ones emerge. Just think about RSV and what has happened just over the course of the past months to a year. There is no immunization against this. I am a professor, as I have said, at the INRS for more than 20 years, and it's granting is extremely important to be able to continue the work that is being done there. That passes through the CIAHR, and there is an analysis of the various associations that make requests, including the Canadian Association of Neuroscience. What has been found is that there has been a drop in funding since 2005, some 31% since 2005, as I have said, but also 15% alone since 2018. And also, there has been more than a 25% in the budget that is allotted to research students, graduates who are there seeking bursaries, seeking grants to conduct their research. And that puts them in a very precarious financial situation. It hardly encourages young researchers to join in the work. And according to the OECD, Canada is the only developed country in the G7 that is dropping in terms of the funding for research of this type. The United States is investing 3 times more than Canada per capita. And that indicates the considerable effort that remains to be done by Canada to be a leader in this area. Now, I would like to think about proposing 3 measures that perhaps could be borne in mind by the federal government in terms of biomedical research investment. First of all, increase federal investment in research in Canada by 25% right now, and then 10% per year in the future so that we can compete with other countries and catch up with other countries. Secondly, you have to invest more in infrastructure and do so through the Canada Foundation for Innovation. Third, you have to bring back to a reasonable level what is being paid out to researchers, to students, to make this field, this profession attractive to them. You know, in conclusion, COVID-19 shone light on the importance of having a rich and diversified ecosystem in the area of research. But much remains to be done in the area of research and development here in Canada. Massive investment has to be made to ensure the good health of young children in the coming years. I thank you for your attention, and I'm happy to answer your questions. Thank you, Mr. Lamar.
Member of the Pediatric Surgical Chiefs of Canada, Dr. Eric Skarsgård. Welcome to the committee. Dr. Skarsgård, you have the floor.
Good morning, Mr. Chair. I'd like to begin by thanking this committee for the privilege of attending today. My name is Eric Skarsgård. I am a pediatric surgeon in Vancouver and surgeon-in-chief at British Columbia Children's Hospital and a member of the Pediatric Surgical Chiefs of Canada. I have no conflicts of interest to declare. I've been practicing pediatric surgery in Canada for 22 years. For much of that time, I've been able to deliver timely, high-quality surgical care to children and their families. That has changed. Increasingly, my surgical colleagues and I are unable to look parents of children who need surgery in the eye and tell them with confidence that their child would be all right. This causes anxiety for families and moral distress for our surgical teams who feel helpless in their ability to ensure optimized health outcomes for the children they treat. The root cause is reduced access to scheduled surgery for children due to severe contraction of capacity. This is not a new problem. It was first revealed by the 2007 federally funded Canadian Pediatric Surgical Wait Times Project, which resulted in nationally endorsed diagnosis-specific wait time targets across the spectrum of children's surgery. Delivery of surgical care within a benchmarked wait time is critical to optimizing developmental and functional outcomes, with significant delays threatening a child's vision, hearing, speech development, mobility, and learning potential, with risks of avoidable pain and long-term disability. As late as 2018, national data confirmed that only 65% of scheduled surgery in Canadian children's hospitals was performed within window. With the arrival of the COVID-19 pandemic and the more recent respiratory viral tridemic, things have only gotten worse. Surgical wait lists have essentially doubled, and the percentage of children waiting longer than their wait time target is as high as 70% in some provinces. What factors have caused this? As you are aware, we are in the midst of a human health resource crisis with a reduced pipeline of specialty trained nurses to care for hospitalized children with increasingly complex care needs. But also, these include nurses who work in surgical areas like the operating and recovery rooms, but also nurses who work in the emergency department, wards, mental health, and critical care areas. It cannot be overstated that this crisis is affecting the care of all children, not just those in the need of surgery. The workforce shortage extends beyond nursing to allied health, anesthesia, subspecialty pediatricians and surgeons, including some hard-to-recruit specialty areas such as pediatric ophthalmology and cardiac surgery. Many children's hospitals face space shortages, particularly in terms of operating rooms, minor procedure rooms, and outpatient clinic space. When surgeons are not in the operating room, they are usually seeing patients in an ambulatory clinic setting. Some specialties have very long wait lists for new referrals, and despite innovation in referral management, including centralization and the increasing use of telehealth, there are children languishing on referral wait lists with time-sensitive diagnoses who represent an unmeasured demand for surgery. Less than half of all operations in children 18 and younger are performed by trained pediatric surgeons in children's hospitals. Across the provinces, there is poor integration between specialty services uniquely available in children's hospitals and community-based services with capacity to deliver surgical care to some children. In our geographically vast provinces, this disconnect means that families often travel to a children's hospital to receive surgical care that could be safely and effectively delivered much closer to home. The lack of coordinated funding of hub and spoke models of children's surgical care causes disorganized utilization of existing surgical capacity and uniquely disadvantages families who live outside the urban areas where children's hospitals are located. It also means that there is no line of sight on children waiting for surgery in adult hospitals, where they represent a tiny piece of the pie and risk being overlooked for adult surgical priorities like joint replacements and cataract surgery. What can be done? 1, our children need targeted and sustained federal and provincial funding for children's surgical services. 2, our children need pediatric-specific HHR recruitment that will address gaps in all service areas. 3, our provinces need coordinated, integrated health services planning that right-sizes child health services to population need so that children have the right operation at the right time by the right surgeon as close to home as possible. And 4, our children need governments to encourage and fund innovation that specifically benefits child health. This should span the spectrum of discovery research, implementation science, AI, health technology assessment, and regulatory approval so that we are continually improving care and health outcomes for children while introducing efficiency that will drive value in healthcare. More than ever before, our children need advocacy within a public health system for their unique care needs, including prioritization for surgery. Children are not small adults and are not less deserving. Thank you for your attention.
Thank you, Dr. Skarsgård. And finally, Patsy McKinney, Executive Director of the Under One Sky Friendship Center. Welcome to the committee. Ms. McKinney, you have the floor.
Good afternoon, committee. My name is Patsy McKinney, and I'm Executive Director Under One Sky Friendship Center in Fredericton. And I want to recognize that I'm joining you today from the unsurrendered, unceded traditional lands of the Wolastoqey in Fredericton. And I want to thank you for the invitation to appear before the House of Commons Standing Committee on Health today. The Indigenous population in Canada is young, rapidly growing, and largely urban-based. Nationally, approximately 65 to 80% of Canada's 2 million Indigenous people are living in urban settings. The urban Indigenous population continues to expand at a rate 4 times faster than the non-Indigenous urban population. Despite being one of the largest and fastest growing segments of the Canadian population, urban Indigenous children face a range of complex health challenges across a variety of social determinants. Our children continue to be denied their inherent rights and equitable access to culturally grounded, quality services due to unstable and insufficient funding, lack of continuity in a patchwork of programs and services, jurisdictional ambiguity, and a lack of Indigenous control over planning, design, and delivery of programs. And I want to talk briefly about the Friendship Centre movement and the work of it. With a vast majority of centres of Canada's Indigenous population living in urban environments, Friendship Centres fill an essential gap in service provisions as one of the few organizations directly catering to urban Indigenous needs in a status-inclusive model. For more than 50 years, Friendship Centres have aided First Nations, Inuit, and Métis living in urban environments. Collectively, we refer to our network of over 100 local Friendship Centres as the Friendship Centre movement. We're delivering over 1,300 programs and serving over 1 million people per year. The Friendship Centre movement is Canada's most significant and comprehensive urban Indigenous service delivery network. Historically, the Government of Canada has failed to uphold the rights of children and care for their well-being. Public policy decisions and budgetary allocations often do not prioritize Canada's youngest citizens, which is evident at all levels of government. Indigenous children continue to be disproportionately represented in the Canadian child welfare system. This ongoing and growing crisis is the result of lasting impacts of colonization and the residential school system. Compared to non-Indigenous children in Canada, our children are more likely to grow up in families affected by intergenerational trauma, the multiple and interrelated downstream effects of poverty, and to be removed from their homes, cultures, and communities by the contemporary child welfare system. Urban Indigenous children, youth, and families face additional barriers to accessing culturally safe programs and services that affect their needs and best interests, both as Indigenous people and as children. The need for culturally safe and accessible urban Indigenous specific and urban Indigenous driven community support is high and continually growing. There is an urgent and pressing need to ensure that all Indigenous children, regardless of residency, can fully appreciate their rights both as Indigenous peoples and as children. All Indigenous children ought to receive culturally relevant programs and services offered by Indigenous-owned and operated entities, whether they reside within respective communities or an urban setting. Solutions to the health crisis facing Indigenous children can be found within our own communities and our organizations. Friendship Centres have a long and demonstrated history of effectively supporting the health and well-being of Indigenous children through wraparound services. Friendship Centres across Canada will continue to support the holistic well-being and safety of urban Indigenous children, youth, and families. The ongoing threats to the health and well-being of children and violations of children's rights in this country warrant immediate attention, investment, and action by all levels of government. With a solid majority of Indigenous people living in urban areas and as a young and fast-growing population, effective policy, program, and legislation must adopt an urban lens. Urban Indigenous communities and Indigenous-led organizations must be part of any solution to meaningfully improve the lives and future of Canada's children. The Friendship Centre movement is unique in its ability to uplift and support urban Indigenous communities, mobilizing advocacy and collaboration through a national network. All levels of government should be prepared to work with Friendship Centres, community leaders, and Indigenous peoples in urban settings to develop collaborative and meaningful solutions that consider the perspectives of all affected individuals and communities. And I want to thank you for your time and consideration and look forward to answering any questions you may have.
Thank you, Ms. McKinney. And we're going to move right to questions right away, beginning with the Conservatives. Ms. Goodrich, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all our witnesses for participating with us today. I guess I'm just going to start out, Dr. Skarsgård. I want to thank you for providing your notes in advance. It's always very helpful when we have the notes in advance. So one of the questions I had from your notes is you talked about the importance of having a health human resource program and plan that is pediatric specific. And I'm just wondering if you can expand on what that would look like if you were to design something along those lines. What would you want to see in that?
Thank you very much for this question and for an opportunity to respond to the greatest challenge, which is that of human health resource, and that this is a problem writ large in healthcare. I don't think that's a secret to anyone. Our challenge is that the needs of our patients in hospital and out of hospital are unique and developmentally specific. And so we're seeking a human health resource, which largely would be represented by specialty trained nurses who have gone that extra mile to get training that is child specific. These are training programs that are, postgraduate programs. They're usually hospital based. They often require commitment of time and often are not financially supported. And so we really need, this pipeline of nurses to have a significant number of them directed into or incentivized into being child specific in their focus of care. Children's hospital nurses often travel great distances to come and work in a children's hospital. There are community hospitals that are much closer. The unions would pay equivalently for them to work in a nearby community hospital, and it's only their dedication to children that makes them drive farther, commute at greater expense, and really to live out their passion, which is to care for children. And that's something that's shared by all of us who work in child health care. So the answer to your question is really we need to enhance the pipeline, and then we need to direct part of that pipeline and entice them and retain them in a pediatric career.
Fantastic. And I guess that really well leads into my next question. You talked about how that there's a disorganized system that disadvantages families that live outside of urban centers. As an MP that represents a large northern isolated region in northeastern Alberta, there are no children's hospitals throughout my entire riding. And so that means that families in my riding that need those kinds of services often have to go into larger centers like Edmonton or Calgary, which are 5 or 9 hours away in order to get services. But there has been movement in the last little while to have more services delivered at community hospitals. I was just wondering if you think that situations like that would help not only with the health human resources to allow some of these nurses that have specialized to stay in their communities, but also provide solutions to families that are outside of those urban centers.
Yeah. Thank you for this question. And what you described really highlights what I think is the next challenge in children's service planning by the provinces, and that is to really make sure that we are using existing capacity in the most effective and efficient way so that we do limit children traveling to the urban tertiary quaternary children's hospital. I mean, it goes without saying that some children will need to if they have a condition that really mandates the type of specialization that's uniquely available in children's hospitals, then we have to have systems to get them there. But a lot of the care that's provided in children's hospitals is care that could be safely and effectively delivered in community settings. What's required for that to happen? Well, first we need strengthened partnerships with the regional health authorities, and we need to have co-design of pediatric health services planning so that there is consideration for having a certain number of pediatric beds and a certain skill set of nurses and pediatricians and allied health within those community centers to provide the type of care that a child needing, for example, surgery in those centers might need to access.
No, thank you. I appreciate that. I do have a very limited amount of time, and I do want to switch gears a little bit here. Ms. McKinney, the friendship centers, I know in my riding I've got quite a few friendship centers across my entire riding, and they do amazing work connecting with the community. I was just wondering if you could perhaps touch on how important healthy living is for having healthy kids. I've seen some of the innovative work that your Friendship Center is doing, and I'm just wondering if you could expand a little bit upon that. I think that there's quite a bit there.
Sure, absolutely. So we know that children's health isn't based just on the medical system, and I'm sitting here with a group of medical professionals, which is amazing. But it's also what we try to do as a Friendship Center is to come in upstream so that we're providing programs and services before these children end up unwell. And so that means supporting families with some of the programs that we're offering, which can be everything from food security to, I know many of the Friendship Centers across the country during COVID really offered immunization clinics around all of that. So, and we're better prepared than most mainstream institutions to do this because we understand our community, we understand the people that we're serving. And the reality for most Friendship Centers are struggling to be able to do this with a growing population. Just here in Fredericton, I think the Indigenous population off reserve here quadrupled.
Thank you so much. I think we all appreciate hearing this, but I will cede my time because I do know that we're now over.
Thank you, Ms. Goodrich. Thank you, Ms. McKinney. Don't worry, I'm sure you'll get a chance to expand on that. Next, Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being with us today to share your important perspectives. My first question is to Dr. Eric Skargard. Can you discuss the impact of the COVID-19 pandemic on pediatric surgery services? How do you believe that new federal funding commitment will help clear up any backlogs when you talked about the target funding? Can you expand on that?
Certainly. Thank you for the question. One of the other witnesses very eloquently described the impact of COVID-19 on children. And in the Children's Hospital perspective, it was something that we really didn't know what to expect and what impact it would have on children. We did learn some of the things about transmission to children, but really, in terms of comparative impact to adult health services, we did not see children dying in children's hospitals as we did in the adult hospitals. And in fact, what ended up happening is we sent many of our critical care nurses to work in the adult health system, or in some instances, looked after adults in children's ICUs. So it was a very different impact than what was seen in adult health services with COVID. Your question about prioritized funding for children, I think, was next. And I really think that there's always a risk. We are also grateful for these transfer payments, but there's always a risk that children are forgotten because children's services represent such a small proportion. They're less than 3% of surgeries done in my province are in children under 18. So there's been some talk about earmarking a certain proportion of those transfer payments to the provinces that must be used specifically for children's services, and I applaud that and encourage more of that thinking that targets resources specifically to children and does not rely on others to prioritize children with funding.
Thank you, Dr. Skargard. My next question is to Ms. Granworks. I'm wondering about how obesity can impact the immune system. Can you expand on the importance of ensuring healthy eating and active living? I have had chance to visit many research sites, particularly around diabetes, and I know we will talk about the rare diseases too. So I just want to how we can ensure that children are involved in the research process, that their voices are heard when it comes to decision about their health, and to follow up on that, how we can better support parents, caregivers in promoting children's health and preventing the spread of viruses.
Thank you for the question. So you said it right. The obesity and the diabetes has been recognized as the factor for vulnerability to COVID-19 very early in the beginning of the pandemic. And this is definitely comorbidities that are impacting the immune system. It's known in terms of the research, but obviously, it has been more described in adults, and often it is a negligible factor for the illness of children. And as my colleague, Dr. Lama, explained, there is a need for improving the research in pediatric disease and especially infection and the impact of these comorbidities. So I think, there is definitely more research that needs to be done, and I think this should be prioritized in the funding in the next years in Canada and worldwide. We need to have a better understanding on how the life and the comorbidities impact the capacity of children to combat infections. So this can be done through the research, of course, but also, I also like the intervention from Professor McKinney, who said that we also need to work upstream. So I think we need more education on how the lifestyle of the eating, what the children eat, impact on their capacity to fight infection and other disease. So it's definitely a priority. It needs to be integrated, and I think that it needs to be part of the research programmation from the institute that fund the health, but also the social science. All of this needs to come together in an integrating funding to address this question and also educate more. And I think it should also be part of education at school to help the children very early in their life to understand how this can impact their life.
To follow up that, is there any particular area of research or treatment that you feel are being overlooked in the field of children's health?
I think there are many aspects. I think the health of children has been overlooked overall it was described by my colleagues, that it's a limited impact, and I can only take the example of respiratory syncytial virus, from which we heard a lot, but I have been working on that for 20 years now, and it was really overcome before, because we said it's a limited number of children who will be impacted, so it's and also the indigenous people are highly impacted from this compared to the general population. So I think, to my opinion, what is really overcome is actually what you just described before, is the impact of comorbidities on the health of the children in general, like the food that they get, all their life together, or this impact the capacity to fight the disease that will not impact a child who has all the good food and everything, and will have a good immune system to fight all of that. So I think it's more, the correlation between, we have a lot of research on specific disease, but we always ignore that not all children are equal in face of disease, and we need to get the diversity of information about how the children will be responding to capacity to fight different diseases depending on their background and their lifestyle. That's something that we have to put more emphasis on in terms of research.
Thank you, Dr. Granvaux. Ms. Sidhu, Monsieur.
Mr. Thériault, 6 minutes, please. Mr. Thériault. What a wonderful panel. Thank you, Chair. What a wonderful panel, Chair, we have today to finish this study that we have undertaken. We have people who are doing fundamental research and who are part of the ecosystem. I'm going to try, though, to ask some intelligent questions. My first question is to Mr. Lamar, because I think what he said is important. The pandemic revealed to us, or at least showed us, that technology, the knowledge in this area and what to do is something that you have to look at in the framework of upstream. In actual fact, though, what is happening is that we are losing researchers. We are losing our people because bursaries, grants are just pitiful in this area. And these, in fact, are the most important individuals that we need during a time like the pandemic. It was a time of urgent need. So I would like to hear your thought on that. Do you think the ecosystem that we are in now is healthy? Over the past 3 years, has there been a new awareness of what must have to be done? Mr. Lamar, I don't really think that we are acting on anything yet. Thank you for your question. It's very fitting. And in actual fact, there is a chronic problem in terms of investment in research here in Canada. There's been a gradual reduction or even a stagnation in research budgets. Costs are going up, and at the end of the day, really, we have less money to do our research. I can't really say, though, that nothing has been done over the course of the 3 years where we are today. There have been major investments by the federal government, but that's been done in niche areas that were abandoned over the 20 past years. The development, for example, of vaccines, the biomanufacture of vaccines, all were underfunded over the course of previous decades. We've tried to correct that. But there were also initiatives that were targeted, and that is quite appropriate, where significant amounts of money were invested. For example, in the area of the development of vaccines, particularly with respect to SARS-CoV-2. So that virus. But fundamental research has to be the basis for innovation in the future. We have to be able to continue to fund research. We don't know if there will be another pandemic, but we have to continue to fund research over a whole variety of areas if ever there is another pandemic or even a health crisis, or if there is some development in the area of an infectious disease. We have to have a solid basis of knowledge to be able to react very quickly in the future. So it is important to invest in fundamental research. In fact, it is essential. I think that now we are probably the lowest of the G7 in this area. Well, given all your brilliant minds, and in view of the fact that Dr. Granvaux would like to perhaps add something, given all the research that has been done, and I do know from sources that in the course of the 80s, Scripps Clinic, San Diego, IRN, have we're already working on this 40 areas of research that allowed us to finally get out of the pandemic. But when you cut funding, you cut off your arms, your legs, and you shoot yourself in the foot. Would you have something to say about that, Madame? First of all, the basic research that has to be undertaken has not been dealt with in the same way as upstream basic research, particularly in the area of vaccines. But we were prepared in a sense, and it was because of that we were able to move fairly quickly in the pandemic, something that is often misunderstood in terms of fundamental research. We talked about the lack of manpower earlier on, but you have to fund the staff in the laboratories. Other than the professors, we are, of course, professionals, but we often have doctoral students that are there to help and to learn. But if they don't have the salaries that exist in other countries, they won't be there, and we won't be able to be competitive. So when we ask for a bigger budget, often they think it's only linked to our particular scientific interests, but this is actually the crux of the matter. We do need to produce the most performative research in Canada. Thank you, Professor Granville.
Thank you, Mr. Chair, and thank you to all the witnesses for your excellent testimony. Dr. Lamar, if I could begin with you, please. At your appearance before this committee on June 8, 2021, you said the following: according to data from the Organization for Economic Cooperation and Development, Canada is the only G7 country where gross domestic expenditures on research and development have been declining since 2001. It is now the second lowest in the G7 on this measure, ahead of only Italy. If you know, Dr. Lamar, what portion of Canada's gross domestic expenditures on research and development are directed towards child and youth-focused health research?
I wouldn't guess any number, but as other witnesses have spoke to, it's a minority for sure. So there's a lack of funding in general, but it's probably even more pronounced for children's research, and that goes from fundamental research until all the way to clinical trials, which also are difficult to conduct for children, and there's probably also underfunding for clinical trials in children's disease or children's medications that are in development. So I wouldn't want to guess on any number, but it's probably even more severe than what we see for adult research.
Do you have a sense of where Canada might compare with peer jurisdictions in terms of how much we allocate towards research for children and youth-focused health?
Right. It's probably, even worse than the budget allocated to fundamental research in the G7. So yes, we are second, but last in that aspect, and it's probably not better than 20th position in the world for children's research. So yeah, I think there's a lot of ground to be covered.
Dr. Skarsgård, if I can turn to you, is there national data available on the number of children who are on wait lists for surgeries?
There is, if we aggregate provincial data. We used to have a organization through what is now Children's Healthcare Canada that kept track of national data. We rely now on provincially aggregated data. So the data that I provided to you is self-reported from children's hospitals.
Do you see the need for better national data on this? Would that be helpful?
I think I do think it would be helpful, as would be more national cooperation. Child health still is a provincial responsibility, and I think that with greater integration across provinces, with sharing of what's working, what's not, dealing with some health human resource pipeline issues, sharing technology and technology assessment so that we can drive the approval of pediatric-specific devices more effectively in Ottawa. I think there's great opportunity for national collaboration in data sharing and in operational management.
Thank you. Dr. Skarsgård, in a December 2022 article from the Vancouver Sun, you noted that BC Children's Hospital has found ways to add some additional surgical capacity by prioritizing cases that are developmentally timed for the best outcome, such as those for kids with scoliosis or heart defects, kids with cancer, and those coming from remote areas. Can you give us a sense of how much additional capacity that strategy has created, and also what is the current backlog for surgery at BC Children's Hospital?
Well, I would say that we didn't actually create a lot more capacity, but rather we shifted the capacity that we had to those priority areas that you mentioned. We certainly do have some capacity building strategies that include consistently opening additional ORs, running ORs later in the day, and even trying to run operating rooms on weekends, elective surgery on weekends. Sorry, I've just forgotten the second part of your question. Apologies.
What is the current backlog for surgery at BC Children's?
Right. Yeah, so I did provide some figures that show that our current wait list is about 3,800 patients. That's double what it was before the pandemic. And it's important to realize that a wait list is just a number, and what you're not capturing in that number is the percentage of children who are waiting beyond their wait time target, which is really important for some of those developmentally timed surgeries like scoliosis surgery and cleft lip and palate. Those children are on the wait list, and they're waiting longer than they've ever waited before.
I have some data from 2018 that showed that only 65% of elective surgeries in Canadian children's hospitals were completed within window, suggesting insufficient national capacity even before the pandemic, which I think we all realize has been exacerbated. In your view, and you've touched on this a bit, Dr. Skarsgård, what steps should the federal government take to expand Canada's pediatric surgery capacity?
Well, I think we need targeted funding for children's health care with the transfer payments to the provinces. We need cooperation in planning within the provinces between, as I've mentioned, the children's hospitals and the community that really targets the building and retention of child health care capacity. This can't be something that is just a quality improvement project. This has to be something that is identified as a priority and sustained across annual budgets.
Thank you, Dr. Skarsgård. Next, Mr. Genereux, please, for 5 minutes.
Thank you, Mr. Chair, and thanks everybody for joining us here today. I got scooped a little bit by my colleague and friend at the end of the table there, Mr. Davies, on the question that I was going to go on with you, Dr. Skarsgård, but I'll also go in perhaps a bit more detail. Like that, there's two numbers that really stood out, or two, I guess, facts that really stood out in your speech and your testimony here today, and that 65% of scheduled surgeries were performed within the window. And going back, this goes back to 2007. Like, this is a crisis, as you indicated a number of times, but a crisis that absolutely should be being addressed by quite frankly all levels of government across the country. However, your numbers that's a 2018 numbers there that were quoted by Mr. Davies. Has it? I see your 2023 numbers here that it's 58% out of the window. Is this trending in a negative direction? I guess perhaps fill us in a bit on that. But if I could just add my second question to that before I turn it over to you, Is this to unpack some of what you said to Mr. Davies? is this a matter of resources? Like, is it the federal funding should go to more nurses? Should it go to more infrastructure, operating rooms, more hospitals in general? I guess if you can unpack some of where exactly that would make the biggest difference would also be helpful.
Thank you very much for the question. That figure of 65% out of window requires some interpretation because it can, in some reports, it reflects completed cases. So an operation gets done and comes off the wait list, and we are interested in how long did those children wait to have surgery. You can also have an out-of-window measure on children who have not yet had surgery, and that's perhaps the group that are greatest at risk because we don't know when they will have surgery. Maybe they'll be 60, 70, 80% out of window when they finally get surgery. We've shifted our focus to out of window as being an important measure for children who are waiting for surgery because the wait lists have grown so greatly over the last 3 years. So I would say that's still a very, very important number and one we need to keep an eye on, but it also needs to be measured in the context of the total corpus of the wait list in the provinces and across the country. Your other question was with regards to, I'm so sorry, can you just remind me?
No problem. Just unpacking what would be most helpful. Is it for infrastructure, nurses? Yeah. Sorry, one.
Yeah, my apologies. Yes. In my hospital and in the discussions that we have with the other chiefs of surgery at the other children's hospitals, it's nurses. It's nurses that keep our ORs and our recovery rooms open and nurses that staff hospital beds, particularly in critical care areas. So we can have a child waiting for surgery. We can have a room. We can have a surgeon and anesthetist, but without a nurse to staff a bed for that child to go to after surgery, we can't start that case. And obviously you can see that shifts the allocation of resources away from children who need beds after surgery, which means that we use that time in other ways, but it's usually to treat children who don't necessarily need a bed after surgery. Some of the other issues around space and equipment are important, but I would have to say that in my hospital and in most of the children's hospitals across Canada, it is the human health resource that is the limiting factor.
Interesting, because from what I understand too, in British Columbia, everybody has to be in the room. I forget what it's called, but everybody has to be, like the anesthesiologist, the nurse, the pediatric the surgeon, all have to be in the room prior to the start of the surgery and get the patient sign off. I'm going to jump to my second question, but if I'm wrong on that, definitely correct me. Only because I have about 30 seconds left. The other fact that jumped out was the less than half of all operations in children are performed by people other than pediatric surgeons. And are these typically family doctors in rural remote areas? So if you don't have the benefit of living in downtown Vancouver and you're in a remote area in BC, you're getting your surgery. If you don't, I guess, come to your hospital, you're getting it done by a family physician instead?
No, definitely not. These are specialist surgeons who may not focus their practice on children, but certainly can provide care for children. These would usually be children who are older, teenagers who don't have comorbidities that would require the care of children's specialists. So these would be children who need hernias fixed, gallbladders removed, some minor orthopedic surgery. All of these things can be safely and effectively done in the community if the community hospitals are set up to provide care and the providers are incentivized to care for children. They have long wait lists of adult patients, and quite frankly, the fee guide for a fee-for-service surgeon will not encourage them to do a minor procedure in a child if they have an option of doing an operation in an adult.
Thank you, Dr. Skarsgård. Mr. Genereux, next, Dr. Hanley, please, for 5 minutes.
Thank you, and I also appreciate the excellent testimony we've heard from all of you today. So thank you for that. I'm going to try to pick up a few themes that haven't been as much discussed. Dr. Granvaux, first of all, you talked about the need to improve air quality and how we can move towards, matching what we have achieved in public health in water quality. I think one of the difficulties is arriving at standards. And I wonder if you could reflect a little bit on we know that there's already a tremendous variety in air quality depending on the building, the size, the age of the building. So how do we work or develop standards so we actually know what we're aiming for in rather than a more general improving air quality kind of question?
Thank you for the question. It is true, there have been a lot of committees in place, for example, in the US, in Europe, in Belgium, and in France to discuss what should be the standard. So we already have standards that exist from different organizations. But I think from what I have read, and I think experts in ventilation could definitely explain that better than me. But what I see worldwide in countries which have taken the path to improving indoor air quality is to rely on CO2 measurements and to give an idea of how the ventilation and the air exchange is efficient inside. And I think from what they have done so far, it's a good measurement, an easy measurement with the apparatus that are available right now that can measure how the air is changed in an environment. And I think it's really powerful because it will indicate in terms of infectious disease, it's what we need. We need the air to be exchanged to decrease the number of aerosols inside. So I think there are different associations in the world which are committed to defining the standard. They are already out there. So for example, for now, like Belgium or France have decided to go with 800 ppm as a definition. But for example, in Quebec, we are still with 1,500, which is far above what international standards have been decided. So I think we need to discuss with the international commissions to adopt the same standard than them.
Thank you. That's very, very helpful, and hopefully we can work on developing some national agreement. I'm going to jump to Ms. McKinney, changing the subject a bit, and you mentioned moving upstream, and I'm going to take you a little further upstream. How important, when we look at some urgency of our children's health, particularly Indigenous children's health, given the many challenges, both pre- and post-pandemic, there's been a lot of work in the Yukon Territory amongst the self-governing First Nations in particular on developing language nests and increasing that connection with culture, mainly through language development. I wonder if you could just comment on the importance of supporting Indigenous language knowledge development, and through that a greater connection to one's culture.
Sure, absolutely. Well, we know that it's a part of wellness, especially for Indigenous people, and the loss of our language has impacted our entire families for generations. So we know that, and I know there's a whole body of research out there around mother tongue and mother tongue languages for children, and how important that is for them developmentally as well. And so I know many of the friendship centers across the country are trying to focus on restoring and resurrecting our Indigenous languages. We have two languages here in New Brunswick. We have the Wolastoqey language and the Mi'kmaq language, and working diligently on that. But we have to understand that it's a challenge because many of our speakers are aging, and we're losing that. We're losing them. So and so we sort of have a sense of urgency around that. And for Indigenous people, it's all connected. Like we take such a holistic approach towards health and wellness. It's not just about how much you weigh or what your blood pressure is. It's about how well you are within your community and your culture and your language, and how our families are being supported. So that it's really, really important, especially for our children, to realize that their language is as important as other languages. And New Brunswick is the only official bilingual province in the country, and our French brothers and sisters have done an amazing job of making sure that happens for their children, because they know it's really important. So it's not like we have to look outside of the country for that. We have amazing examples here in our own country, in our own province around, we have French-speaking children that can go to French kindergarten, they can go to French daycares, middle school, high school, all the way up to university. But we don't have that. And at a minimum, that's what we're hoping for someday.
Thank you,
I
Ms.
don't know if I answered your question.
Thank you, Ms. McKinney. Monsieur Thériault pour 2 minutes.
2.5 minutes, Mr. Thériault. Yes, 2.5 minutes. My question is to Madame Grammer. We were told recently, listen, it is possible that the next pandemic that would be on the horizon would be one because of a resistance to antibiotics. Do you agree with that? This was the Centre Saint-Justine that feels that viruses increase has also been coordinated with the increase in severe bacterial infections. Do you not think that there is an obligation somewhere to maintain or perhaps increase immunization to avoid that situation? Perhaps I could quickly answer. Yes. The resistance to antibiotics is something that we have been very concerned about well before the arrival of the pandemic of COVID. There is Canadian funding that is dedicated to looking into this, and it should be continued. But the impact of viral infections and their impact on bacteria. We are also studying that there are a certain number of bacterial infections that are airborne. They are transmitted in this way, and with these infections, we would have to be able to try to limit their impact in that way. I'll give the floor to my colleague. Yes, I would have said the same thing. And what I could add, though, is this. Unfortunately, there are few incentives for the major pharmaceuticals to work on new antibiotics. It is a market that is extremely complicated, complex, competitive. And so once again, we have to rely on research that has been done in the university sector. In a large part, we're talking about federal funding in that case. And so this reflects my request for adequate funding of research at universities. Yes, but do you think that something can be done upstream to avoid a possible pandemic through, say, immunization in this way? Well, absolutely. There are people who are working in that area, and you have to target the broadest possible immunization coverage. But we don't, unfortunately, have vaccines for all infectious diseases. And in my remarks, I spoke about RSA. And you know that there is also malaria. There is really, in fact, a panoply of other types of viruses.
For 2.5 minutes.
Mr. Chair. Dr. Skarsgård, help me get a better picture, more clear picture of the state of operating room capacity. I don't know if you, obviously you can speak about the capacity at BC Children's. I'm wondering if you know of it more broadly, but are our operating rooms being utilized at full capacity right now?
Thank you for the question. We have operating rooms that at BC Children's Hospital, and I know for example, at Sick Kids and the larger children's hospitals in Ontario. I know less about Alberta, but we have children's operating rooms that are fallow. They're empty, and it relates to the fact that we aren't able to staff them. The point was made that you need a full team. You need a surgeon, anesthetist, nursing, RTs. There's lots of human resource that goes into being able to run an operating room, and you need every critical piece to ensure a safe operative encounter for a child. So I would say that we don't really lack in many of our hospitals in physical capacity, but it's the staffing that's required to safely and efficiently run an operating room. In terms of our operating room efficiency, what we do notice is that when we shift the focus from elective care to urgent emergent care, and it's important to realize that throughout this period we have never neglected our obligation to look after children who are in need of urgent surgical care. But if you shift a resource that is intended to be used efficiently electively to support emergency care, so instead of running 8 elective rooms, you run 4, and then you run 4 urgent rooms, that's where your efficiency really goes down, because you're changing. In a single day, you may have a heart operation, an orthopedic operation, and an appendectomy. And when you do that, when you're shifting teams in and out of rooms, that's where efficiency really takes a hit. So it's a two-edged. It's a capacity that needs both the guarantee of an elective schedule to run efficiently, but also sufficient capacity that you can get at the patients that are on the wait list waiting and really dig into those and make reductions in those long wait lists.
Thank you, Dr. Skarsgård. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for being here, and it's greatly appreciated. And so my first question, in fact, some of my questions have already been sort of touched on, so I'll try and touch a little bit differently on them. But Dr. Skarsgård, and thank you for your presentation. You talked a bit in your point number 1, which was on dealing with the lack of skilled specialized nurses. One of the smartest, most hardest working and most compassionate people I know is my wife, Donna. And she started her career as a neonatal intensive care nurse at the ICU at University of Alberta. And then she went to the ICU at hospitals for sick children. And she was there for a number of years, and we got married, and then she moved from there to the Sunnybrook Trauma Center. And she did all this progressing as she went along. And your comments about how do we improve these nurses' skills and get them to be involved, I think is very commendable, and it is something we need to look forward. I'm wondering, has the Pediatric Surgical Chiefs of Canada, have they actually talked to the regulatory bodies or to the universities to actually even look at providing these programs and how they can move forward on that?
I can't say that the surgical chiefs have directly, but through our strong collaboration around advocacy with Children's Healthcare Canada, I know there have been some conversations at the level of, provincial nursing colleges trying to create more seats for nursing, and then specifically trying to incentivize a diverting pipeline of nurses that then go in to dedicate their careers, as your wife did, to that of child health. What we do see is the phenomenon of nurses who drive by many community hospitals to commute to work at a children's hospital at personal expense, and it's because of the dedication that they do that. We need to create more of those nurses who are dedicated to their professional career in looking after children and families, and we do that through advocacy in the provinces. And we do that, as was mentioned, in collaboration with these groups that are across Canada, so we can also bring this voice to you to also drive that message that we need to target resources of all kinds, but particularly for recruitment and retention to a pediatric health workforce.
Thank you. And one of the challenges that we see across Canada now is basically traveling nurses, where they're traveling all over the country and all over the world and taking their skills to various levels, which is a huge challenge. I live now, my wife and I moved to rural Saskatchewan, and so as in many of my colleagues, we deal in rural areas, and we're challenged in those areas to ensure that we have appropriate staffing. You mentioned quite clearly about community hospital centers having the ability to try and keep people in those local communities before we send and parents send them to, or the doctors end up sending them up to the specialty hospitals, in particular the children's hospitals, for example, the Patterson Children's Hospital in Saskatoon or in Calgary, et cetera. So, I mean, ultimately, these are challenges. The concern that is out there is that people today, the public, tends to turn around and go and look at Dr. Internet and Dr. Social Media as they're answering to choose and determine what their problems is. And through that, they then jump on that to say, I've got to go to these and clog up a lot of the children's hospitals or even our mainstream hospitals. And I'm wondering, how do we go about solving that? What steps can we do to try and get Canadians to understand that their practitioners are where they need to be getting their advice from?
Yeah, it's a really good point, and I think it speaks to the need for a strengthened, increased capacity and strengthened relationship of the public with primary care and primary and family doctors, because that's really should be the source of advice for families, particularly if they're seeking or need specialty care. In terms of trying to create capacity and create confidence in the community, in community health capacity for children's services, I think part of that is a partnership of children's hospitals with those communities and with the providers in those communities, where there is a sense, whether it's just from almost a branding, but even just presence. I mean, many of our specialists go to many parts of the remote areas in BC to do outreach, to have cardiology clinics in remote areas. And digital health allows that opportunity as well, where we can use telemedicine to meet families in their communities, but give them the sense that they are really closely linked to specialty care. And I really think that it's that strengthened partnership with community where we create child-specific and child-safe capacity to deliver care in those communities, that families will get confidence that it's safe for their 10-year-old child to have their hernia fixed by a general surgeon in Prince George, rather than travel all the way to Vancouver.
Thank you, Dr. Skarsgård. Mr. Vancouver, please, for 5 minutes.
Thanks very much, Mr. Chair, and thank you to all the witnesses today. It's been a fascinating meeting so far. Look forward to hearing more. One of the things that I've been preoccupied by in listening to some of the testimony today is how much more valuable an intervention is, a health intervention, at some point early in a person's life, as early as possible, actually, particularly if they're dealing with adverse health conditions early on, like a rare disease or something like that. So my questions are around that, about early intervention for people and how that can have a positive impact on the trajectory of their life. Last week, on our break week, I was fortunate enough to go out to Canmore, Alberta, to take part in an organized activity with Spirit North, who's a sport organization, a charity that provides sport, physical activity, and recreational opportunities to Indigenous youth, First Nations youth primarily, throughout Alberta, Manitoba, and Ontario. And it was awesome to see so many smiling faces and see so many young people loving and enjoying moving and physical activity. So my first question is to Ms. McKinney, and I'm curious about specific interventions that would address and improve children's health issues from an Indigenous perspective, and how our government can more thoroughly address and support these types of interventions. So any studies, programs, or policies that you see that have been making a difference, and things that we should do more of.
It's a great question. So one of the things that we're doing here is land-based learning. So we developed, it's a nationally renowned program called Take It Outside. So it's a way of getting our children out back on the land. So it's not just a matter of taking them out on the playground. We take them to an old growth forest with, very natural environment. And it's also a great way for us to teach them their language in that environment. And some of the challenges that, we face is we have families that are living in substandard housing with really poor air quality, overcrowding. And so all of that leads to really poor health, and especially for our children. And so those are some of the things that we're trying to do. And we actually had a bit of a kickback from the province here around our Take It Outside program during COVID. So they called it a field trip. It's not a field trip. It's a part of our curriculum, is to get our kids back outside on the land. What's more healthy, stuck in a classroom or out on the land? So those are some of the challenges that we face, which is why it's really important for us to be delivering some of these programs as opposed to mainstream. And I know that mainstream has, wonderful intentions, but it doesn't always work out well for Indigenous families. So these kinds of programs are become really valuable to community. That's one of the things that we're doing. Is this land-based learning, but we're also now bringing it to adults. So we have land-based learning for university students. And all of that we think is really, really important. It also connects non-Indigenous students with Indigenous students, which speaks as well to wellness and what some of the issues that we have to deal with here. But if we've got families that are living in poverty and substandard housing, and they're being faced with a multitude of really poor health issues. So you can talk about really healthy food, but how do you afford to buy healthy food when you're living on a fixed income? And so those are some of the things that we're trying to get a little further upstream about before folks end up in the healthcare system.
Thanks, Ms. McKinney. And you kind of took the words out of my mouth for my my segue to the second half of my question with respect to being able to prevent people from having to access the healthcare system. It's a little bit of a guess that I'm making, and I was hoping that one of the doctors with this insight might be able to provide some insight as to whether or not this assumption is at all correct. But when we're talking about lifestyle interventions to prevent people from having to access the healthcare system, I imagine a lot of those are far more effective for adults because they've lived longer and they disproportionately probably suffer from more lifestyle-related illnesses, like type 2 diabetes and others. But I imagine that those are becoming more and more a priority for children's health as well. Would any of the pediatric experts or the doctors on the call like to comment on the value or the necessity of preventing children from having to access the healthcare system? Ms. Granville.
So it's a bit far from my expertise, but what I would say as a citizen maybe is that, and from my reading from the literature, even if it's not my direct expertise, is that, I agree with you that, the lifestyle impacts the disease that we see in adults. But, it's a lifelong story, and everything we do when we're young is also impacting, our health when we become adults. And I think the sooner we teach our children how to get good food with all the limitation that Ms. McKinney just described, you need to make that available, and also physical activity. All of this is something that the children, when they become adult, will have in the, it's a baggage that they have with them and that will help them on the long way. So I think it's not because we see the disease when we are adults that the behavior when we are kids is not having an impact on the long term. So I think we need to act as early as possible, and I think there is a benefit to introduce that and avoid children to go to the healthcare system when they are kids or adults.
Thank you, Dr. Granville. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. To switch gears a little bit once again, I'm going to start with Ms. McKinney. In some of the wraparound supports and services you provide, do you guys do anything to help attract more appropriate and culturally sensitive prenatal care so that kids get the best start from the very beginning?
Well, we don't hear specifically. So one of the things that we did do, we partnered with Horizon Health, and we now have a nurse practitioner that comes to us and is available to many of our folks that come to the Friendship Center. So that was a big help for us. And so we noticed that it's most of the time it's moms with young children that are going to her. And one of the things that we're hoping to work on is hoping to build is a birthing center. right here in our new building that we're hopefully going to have within 2.5 years, and so that our families can come and be able to do those things traditionally with a really good healthcare provider, but going back towards midwives and doulas and delivering babies in a more traditional way, which is you have many people that are pretty excited about that. And I do believe at the Friendship Center in Halifax, they had their first child born there at the Friendship Center, which was pretty exciting. So, and those are what we realize is that many of our families that are struggling with health or mental health issues will hesitate going to mainstream services. And why is that? Because of the amount of judgment they face. So sometimes it might start off as a small, insignificant health issue that will grow because it's not getting addressed because they're not going for help. But they will come here. So we're trying to provide the medical services here at the Friendship Center so that they don't have to go into mainstream service. I mean, there's some things that they will have to go to for specialized services, of course, but it's to get them comfortable to come here because of what they're facing in some of these institutions that they're going to. So one of the things that we're working really hard on is cultural sensitivity training for the medical profession here in New Brunswick, because people are hesitant to reach out because it's not always safe for Indigenous people culturally.
Oh, thank you. That's spectacular. I think if more organizations did things like that to have culturally sensitive approaches to childcare and childbirth, I think we'd be in a very good spot. As someone that I used a midwife with my first pregnancy, and I'm intending to use a midwife again with this current pregnancy that I am in, I think that it can be a very good option for people that are low risk. And as you pointed out, when the choices between no prenatal care and prenatal care with a midwife, I think that's a great idea. So I guess to switch gears a little bit again, Ms. McKinney, what other services would you like to see be able to come into friendship centers like yours and across the country to specifically assist children in getting the care they need?
Well, after school programming, anything to do with education, our kids have to go to mainstream schools. I don't know what it's like across the country in other places, but here, I think the highest level you can go to in community, I think is grade 6, maybe 1 or 2 First Nation communities have grade 8, but then they're going into mainstream school. So one of the things that we're really want to develop is after school programming so that the kids can come here. So right now we have a Head Start program, which is I'm hoping that everybody's familiar with Aboriginal Head Start in urban and northern communities. That is a federal funded program that's been around for 27 years now, and we have one. I think everybody should have one. And the beauty of the Head Start program is it embraces the entire family. So it's not just about you dropping off your kids and you go on your way. We embrace that whole family. And that's what's really, really important around delivering programs and services to vulnerable populations. So it's, mainstream will take a child and you're just going to deal with the child. We don't operate that way, and that's why it's so significantly important. So if you have a child on the autism spectrum disorder, you have a family dealing with the autism spectrum disorder. It's not just about the child. So these are the programs that we're working really hard to develop, but of course we're under-resourced, don't have enough capacity to do that. We're working hard around, being able to be able to deliver some of these programs. I have a wish list that's 20 miles long about programs that I wish I could deliver. And the need is growing faster than we can provide the services for because the population is growing. And we also have 2 universities here in the city of Fredericton. So we have Indigenous people coming from across the country to attend university, and they're bringing their families with them. And their first port of contact is often a friendship center. They may have been familiar with a friendship center wherever they're coming from. So the first place they hook up to is a friendship center. And we're hoping that we can have more Head Starts. There's one in New Brunswick. And I say that, because somebody should be embarrassed and ashamed that there's only one Head Start in New Brunswick. There's only one in Nova Scotia. There's only one in Prince Edward Island, and we have 3 in St. John or in Newfoundland and Labrador. So these are early intervention programs because we embrace the whole family. So that's sort of the model that we try to use. It's not just about dividing people up into whatever they need, whether it's mental health or, food security. It's a holistic approach to most of what we do.
Thank you, Ms. McKinney. Next, Mr. Joe Harry, please, for 5 minutes.
Thank you, Mr. Chair and colleague. My apology for not joining you in the room. I am recovering from a cold, and I just wanted to make sure that you all stay safe. Dr. Skargard, thank you for your testimony, and the same to all the other witnesses. On your recommendation number 4, you specifically said, all children need government to encourage and fund innovation that specifically benefits child health. This should span the spectrum of discovery research, implementation science, QI, AI, health technology assessment, and regulatory approval, so that we are continuously improving the care and health outcomes for children while introducing efficiency that will drive value in the healthcare. Dr. Skargard, can you unpack the recommendation, specifically the whole spectrum that you talked about, as with the perspective of one of the leading children health issues that we are dealing with in Canada?
Sure, and thank you very much for this question. And I'm fortunate to have on this panel of witnesses people who can speak much more scientifically and eloquently about the discovery research, sort of the biomedical research, realizing that Canada has traditionally funded a spectrum of research from biomedical to health services research, and I'm just trying to cover the waterfront with that statement. My expertise would be most appropriately applied to the latter half of those priorities at the end of that sentence. I think that artificial intelligence has great promise for children's health, and I think that making that a funding priority it should be very, very clear to everybody on this call. The last 2, health technology assessment and regulatory approval, are something that really hit home for me as a practicing surgeon, because many of the technology and surgical devices that we use in children really are off-label, meaning unregulated uses of technology and devices that were developed for adults. And that presents challenges from the perspective of Health Canada, in the sense that we are not allowed to get into this country some devices that are the standard of care for children's surgery everywhere else in the world, particularly in the United States. And that is a problem that is not unique to surgical devices, but also to pediatric medicines. And it relates to the fact that the market for some of these, in my instance, surgical devices is so tiny, even when you extrapolate it across Canada to 16 children's hospitals, that the companies that make this technology, is just not worth the expense of getting approved in Canada. So I think this was something that was really unveiled in the pandemic, when we had supply chain issues and we simply could not get diagnostic tools into Canada, and it forced some of these regulations to be fast-tracked. But I would just highlight that is a deficit in our care that is something that I think is within the control of this group and others, to allow greater consideration of medicines and devices that are proven safe and effective in other jurisdictions, particularly with the FDA, and to see ways to get them into the hands of care providers that are uniquely interested in applying that device that is approved for use in children.
Thank you. I see a number of other witnesses today are nodding their head as you're speaking and you're responding. The floor is open to all of you if anybody wants to add any comments to the. Go ahead.
Yes, regarding that last point, I would add only that this is good not only for devices and medication, but for vaccine development, and we've seen that during the pandemic, that we're really dependent on the proper evaluation by Health Canada of vaccines, but we need to move in a very efficient manner. So to rely on other jurisdictions to speed up the process is something that I think was done in that current situation, but needs to be expanded probably to other development of other biomedicals or vaccines or cancer, so that we don't reinvent the wheel every time. So of course, there's always going to be some specific needs and country centric jurisdictions and things like that, but the main scientific problems stay the same, and you don't have to redo the whole thing every time, I guess.
I know I'm out of time, but if I ask the chair indulges, I'd really like to hear from Dr. Grandau. So if you could give us a 30-second addition to that response as well, appreciate it. Thank you,
Very
Chair.
briefly, please.
Yes. I just want to say that the transition from research to translational to application for children is also something where we can make the same comment. And I've witnessed, major improvement that could be done for RSV infection, and that was blocked because we needed a company to make something special for children, which didn't exist. But the market is too small, so it's blocked. So with specific funding, we could solve that this transition and have children-specific treatment that are in the research pipeline, but we cannot apply because of these limitations.
Thank you, Dr. Granvaux. Mr. Thériault pour 2 minutes et demie.
2.5 minutes, Mr. Thériault. Yes, Dr. Skargard, you talked about a crisis in human resources. Would you be able to give us the various factors that are at the origin of this human resources crisis? In Quebec, we have had a variety of problems with retaining our human resources, our manpower, but are there faculties of medicines that are involved? Have they come up short, or have they not planned in advance? And does that have an effect on the numbers that are trained? And of course, there's always the money factor. So there are certain medical disciplines where they will, in actual fact, be deserted. They will be deserted because of a lack of human resources. What is your thought?
Well, thank you for the question, and it's one that has, I think, a complex answer depending on which component of the human health resource team you are talking about, and realize again we're focusing on child health teams. I think we've spoken quite a bit about the need for more nurses. I would just highlight in passing some of the other areas. Allied health for children. These are respiratory therapists, physiotherapists, occupational therapists, child life specialists. All these people are very specially trained and have skills that are specific to the care of children. You did bring up faculties of medicine and workforce planning that I think refers to the physician members of the provider teams at a children's hospital. This is a very significant challenge because we are often recruiting to very, very targeted needs. I'll give you an example. We have a challenge here in the need for an ophthalmologist that treats a very specific and rare type of childhood retinal cancer. Where do you find those people? We don't train them in every province. They are trained internationally. And a barrier to bringing them onto our faculties is at the provincial level, and it relates to physician licensure. And I think that there does need to be greater cooperation between the provincial colleges of physicians and surgeons to see how we can tap into this pipeline of expertise that isn't created within Canada, but exists in North America and internationally. And we really need fast-tracked ways of being able to identify a workforce need and then fill it through recruitment. I hope that answers your question.
Thank you, Dr. Skarsgård. The last question for today's panel will come from Mr. Davies. Please, 2.5 minutes.
Thank you, Mr. Chair. Ms. McKinney, I don't know if you touched on this, but I'd like to probe a little deeper if you did. In January of 2022, the New Brunswick Institute for Research, Data and Training and Under One Sky announced a partnership to study the impact that the Head Start program has had on participating families, as well as examining inequities between the families who applied and the general population of New Brunswick, pardon me. Could you provide this committee with an update on that research?
Well, it's really early on, and so it took quite a bit of time to get it, all of the ins and outs of it to the province and to that department of the university. So we've had multiple research projects that we partnered with the university on, and we realized that if we can do this and do it really well, we'll be able to use it across the country, because we have 133 Head Start sites spread out across this country. And so it took a while for us because we wanted to make sure that the integrity of our families and their children is protected. But we realized that when kids enter here, and we also kept the information from the children that were on our wait list. So in the beginning here, we were licensed for 6 children. Think about that for a minute. 6 children. Anyway, and we're now licensed for 9 children. This is a huge population, but anyway. So we realized early on that, so we kept our files for the children that didn't enter. And if there is a possibility that we could do some comparisons once they get into mainstream school as well. So like I said, it's still very early on in the process. We're working with, and I'm not a research expert on anything. I've been participating in a lot of research, but I'm not an expert. But what we have learned over the years through the Urban Aboriginal Knowledge Network was that the data can be really useful in for us to be able to leverage funding and resources. So, but we'll keep you posted if you're interested in that, because we're very interested in how this could unfold for the Head Start program across the country, actually.
Thank you, Ms. McKinney, and thank you to all of our witnesses. As I indicated at the outset, this is the final witness panel for the Children's Health Study. It's been a fascinating and varied course that we've taken through the various panels, so I guess it's appropriate that we end with one that it was both fascinating and varied. Thank you all for being with us. Thank you for being so patient in sharing your expertise. And we wish you a good day and many thanks. Colleagues, we're going to move now to committee business in public, unless that the will of the committee is to do otherwise. I don't propose to suspend, because although the original plan was just a couple of housekeeping items, there are a couple of other items that are going to be raised, I understand. If I could ask you to deal with the housekeeping items first. One is the study budgets that have been circulated to you, and the other is simply a deadline for the submission of amendments on the private members' business that's coming to us next week. So could I have a motion? Is it the will of the committee to deal with these study budgets as a group, or do we need to talk about, okay, I see at least some heads nodding. Could I have a motion to adopt the project budget for the main estimates, which is Thursday's topic, Bill 252, which is coming before us next Tuesday, and Bill S203, which might be coming to us next Thursday unless something else happens today. Is it the will of the committee to adopt these budgets as presented? because we're in public, I think we actually need a mover. Mr. Davies, do you care to make the motion?
I do,
Okay.
Mr. Chair, so moved.
Thank you. Any discussion? Any opposition? Seeing none, passed by consensus. Thank you. For Bill C-252, Ms. Latanzio's bill that's coming to us next Tuesday, we are required to set a deadline for the submission of amendments because unrepresented parties also have a chance to propose amendments. I would like to suggest this coming Friday in order to have time to have them circulated. Do we have the consensus of the room to set a deadline for the submission of proposed amendments this Friday? Do we need a motion on that as well?
At noon?
So,
we would need a motion.
Okay, so I need a motion to set the deadline for Friday at noon. Ms. Goodrich, thank you. Is it the will of the committee to adopt the motion? I see consensus. The motion is adopted. Thank you very much. Those are the housekeeping items that I wanted to deal with. Now I understand that there may be at least one or two other motions. The floor is open. Mr. Lake.
So I believe today that we will have unanimous consent for this motion that the preamble, long title, and all clauses of Bill S-203 be adopted on division without amendment, and that the chair report the bill to the House.
We're in committee business, so the motion is in order. Is there any discussion on the motion? Seeing none, is it the will? Monsieur Thériault.
Yes, we could pass it on division, could we not? Yes, okay. Is it the will of the committee to adopt the motion on division?
Adopting the motion on division. Okay, I see consensus in the room. The motion is adopted on division.
Chair, I just wanted to add this for the benefit of all the members, that I wanted to highlight the work that was done by Mr. Lake to deal with this bill, to report it. He did so with brio, with determination, but with a great sense of diplomacy, which was very much appreciated by my party, and I would think by all sides, that has allowed us to reach a solution like this. I think that he's the best. He's the best spokesperson for this cause of all parties and of all conservative colleagues in his party. So I certainly congratulate him. Very well said, Mr. Thériault.
It's adopted. Congratulations, Mr. Lake, and thank you, everyone. I think Mr. Thériault speaks for us all in that regard. Mr. Davies, please.
Thank you, Mr. Chair. Well, I would add my voice to that as well, and thank Mr. Lake for his championing of this issue. I think that he represents Parliament so well on this issue, and I want to thank him for his hard work. I would like to move a motion. We last, basically just scheduling, we at our last meeting decided to adopt or to study the PMPRB issues, but we left it to schedule. So I would propose that we set aside 2 days, and on any two of the following, either April 25, April 27, May 2, May 4, May 9, or May 11.
Motion is in order. Is there any discussion? So essentially, we have already adopted a motion to conduct the study. So the motion before you is that the study be held over 2 days, and there's 5 dates listed, of which we would take up 2 of them. Any discussion? All those in favor of the motion as presented?
Chair. Yes, Mr. Thériault. Given that we agreed at our last meeting that the next study would be the one on PMPRBs, I know work has to be done. I have no problem with that, with the study being the next one that we undertake.
All those in favor of the motion as presented, do we have consensus to adopt the motion as presented? Passed by consensus. The motion is adopted. Is there any further business to come before the meeting? Very well. Is it the will of the committee to adjourn? I see consensus. We're adjourned. Thank you.